Well, ladies and gentlemen, good morning. It is wonderful to have you with us today. And a good afternoon and a good evening to our friends and colleagues elsewhere around the world. My name is John Allen, and I'm the president of the Brookings Institution in Washington, D.C. And on behalf of Brookings and our John L. Thornton China Center, I'd like to begin by offering my profound thanks to this distinguished group of leading public health experts for joining this important discussion today. We will use our time together to look at the public health experiences and lessons learned in the fight against COVID-19 in Asia, and then examine where the world may be heading in its fight against the spread of this virus. I'm pleased to be joined by so many renowned public health from China and Japan, Singapore, and South Korea. The strong participation in this event, including with an audience of individuals from around the world, is reflective of the collective spirit that it will take to overcome this disease. Given both the increasing spread of COVID-19 and the importance of relations between the United States and Asia today, this meeting, even in virtual form, is vitally important. Today's webinar seeks to address three fundamental questions. At an epidemiological level, how does COVID-19 differ from SARS, MERS, and Ebola epidemics, as well as other flus, and how should that temper our response? Number two, what response has worked well in each country and what hasn't? And third, how should the United States and other countries prepare for what's to come during the outbreak in the aftermath, which we anticipate? Our goal is to identify practical, actionable recommendations that can help governments in the United States and around the world improve their ability to save lives and to stop the spread of this virus. To help guide today's discussion, I'd like to propose what we'll call the 4R conceptual structure. In other words, response, recovery, reform, and renewal. What is the urgency of our response? How do we collaborate in recovery? And in recovery, how do we seek to reform those things that need to be changed? And how do we renew relationships and institutions to prepare them for the future? The 4 Rs. All of these segments in combination can set the world on a different, more hopeful course. Even if governments do not seem able right now to coordinate or to cooperate on COVID-19 in response, this does not mean that we should abandon hope, and it doesn't mean we can't move forward as peoples. In a crisis that has seen responses veer from minimizing the seriousness of the epidemic to overstating its threat, today's discussion will present a clear-eyed and balanced estimation of the real challenges we're facing as a community of peoples and a community of nations. Each of today's panelists have had to confront real-life questions about what an effective response to COVID-19 should look like at a governmental level, at a societal level, and at a medical professional level, and often all of those simultaneously. I want to encourage all of our panelists to explore specific lessons learned from this pandemic and point to ways that may be helpful in fighting it going forward. I also want to underscore the immense challenge, but also the opportunity that this crisis presents. We have not seen such a devastating pandemic on a global level since 1918. But unlike in 1918, we now have the capability to rapidly and effectively exchange knowledge and information and coordinate across borders and to share relationships as people, if we choose to do so. If we take this opportunity to cooperate and to coordinate rather than to blame shift or close ourselves off to information, we have the chance to come out stronger. We have the chance to be a stronger world through international cooperation against smallpox, malaria, HIV, and other diseases. I strongly believe that at this critical moment, it's most important for us to look forward to finding solutions instead of looking backward in search of scapegoats. Our future, our collective future, will be defined by how we treat others, whether we come together and how we come together at this perilous time. And as president of the Brookings Institution, I am determined to focus the collective capacity of this institution on generating big ideas for building a stronger future. And today's event is an important element in that effort. So again, I want to thank you very much for joining us. This is a critical moment, and all of us are in this together. So with that, let me also then invite to the microphone our interim vice president and the director of our foreign policy program at the Brookings Institution, Dr. Suzanne Maloney, who will introduce our first panel. Suzanne, over to you, please.
Good morning. I hope you can hear me. My name is Suzanne Maloney, and I'm the Interim Vice President and Director of the Foreign Policy Program at the Brookings Institution. I'm honored and humbled to be joined by such a prestigious group of participants from many different time zones to join in conversation about the most important issue of our time, which is how to defeat our common global enemy of COVID-19. I would like to thank our staff and scholars in the Brookings China Center under the direction of Cheng for its foresight in arranging this webinar. In addition to my management responsibilities at Brookings, I study Iran, which is one of the countries that has been hardest hit by this virus. Given the experience in Iran and elsewhere in the world, I know that the experiences and lessons we hear today from our esteemed friends in Asia will not only serve to inform us in the United States, but their advice has the potential to help leaders everywhere, especially in those countries that have not yet felt the worst impact of the virus and still have time to prepare and to flatten the curve. I want to be clear that today's webinar is not politically motivated. Our purpose here is not to highlight some countries or political systems as having done a better or worse job than others in combating this crisis, but rather to build on our common humanity and uncover best practices that can be shared with others in need. In short, the ultimate objective of this webinar is to save lives and to stop the spread of the virus. In this first panel, we will hear from experts in Asia, namely China, Japan, South Korea, and Singapore, who were among the first to confront this disease, each taking different measures with various levels of effectiveness. They will share the experiences and lessons they have learned that can be applied elsewhere. I now turn to my colleague and co-moderator, our Michael H. Armacost Chair and Fellow in the John L. Thornton China Center at Brookings, to introduce our panelists. Welcome, Ryan.
Thank you, Suzanne, and thank you, John, for your framing remarks. Our first panel will be comprised of three components. I will ask each speaker to make brief opening interventions. Suzanne and I will ask each speaker several follow-up questions from their presentations. And then we will open up the floor to questions from our global audience. We will be accepting questions from our audience throughout the event, which can be submitted by emailing to events@brookings.edu or by sending a direct message to our Twitter account @BrookingsChina. In the interest of time, I will be ruthlessly efficient in my introductions of each speaker, but their full biographies are available on the website for this event if you would like to know more about their backgrounds. We will start our presentations with an intervention by Dr. Soonmin Kwan, who is a professor and former dean of the School of Public Health at Seoul National University in Korea. He is the founding director of the WHO Collaborating Center for Health Systems and Financing. He has kept close tabs on the outbreak of COVID-19 in South Korea and will be able to share his perspective from there. Over to you, Dr. Kwan.
Thank you. I'm an economist, and so I'd like to comment on three major issues from a policy perspective that I observed from the Korean government or Korean responses to this COVID. those three are mainly governance issues. And then another very important component is mass testing. And number three, contact tracing. I think these three components issues are closely interconnected. And as a result, so far, I mean, I understand it's a bit too early to say this, but so far we seem to manage it, the slowdown, the rapid increase in infections without a major lockdowns. So let me comment those three elements one by one. I think the first one is the governance issues. Governance, trust in the government, a trust among society, or transparency is quite important, especially in this type of pandemic emergency situation. And also there is a policy learning component in the context of Korea, because about 5 years ago, Korea had a painful experience of MERS, Middle East Respiratory Syndrome. And at that time, Korea experienced one of the largest casualties outside of Middle East. So after that, government recognizes the importance of the preparedness to this type of health security issues. So Korean Center for Disease Control was strengthened a lot. So this in this COVID crisis, every day, I mean, at the beginning, twice per day, there is a briefing headed by the Deputy Minister, sometimes the Minister of Health, and the Director of the Korean Center for Disease Control. They gave a very detailed statistics on how many patients from which areas. And then there is also a mass, like a social campaign, and people seem to quite well complied with these government recommendations without any enforcement issues. So all people wear masks in the public place, and there's a kind of social pressure such that if you don't wear a mask in the public place, you can feel the pressure that people are staring at you. Why you don't wear a mask? And people voluntarily cancel meetings. So even if the restaurants are all still open, no lockdowns, but there's overall compliance with this social distancing strongly recommended by the government. And this governance issue is accompanied by a very rapid, very early and mass scale of testing. Okay, I mean, at the beginning, I think around the world there might be some discussions whether mass scale testing is needed or not. But it turns out that this COVID-19 is very rapidly infecting others. So it turns out that the mass scale of testing is a quite effective mechanism to find the cases, isolate the cases, and treat the infected people. So, and also it's quite impressive that even around the end of January, at that time, there are only like less than 10 cases in Korea, but government talked with the industry, and government provided fast-track approval for the production of test kits. So because of that, we didn't experience any kind of shortage of test kits. It's a huge mass production of test kits, but it very soon it became obvious what happens to this large number of cases, because with mass testing, there's a huge increase in the number of tests, in the number of positive cases. So at the beginning, all the positive cases were hospitalized. And then we realized that then we don't have enough beds. So then we started to allocate beds based on the severity of the cases. So if we see a very severe COVID patient, they are hospitalized. But if for the milder cases, they are staying in a government designated facilities. I mean, it's kind of a residential or training facilities used by large corporations or government public enterprise, but it was converted into a residential facilities, and they are staying there, but they are monitored by doctors even for this milder patient. And another interesting case is that at the very beginning, there are some cases of infection of the test areas, testing stations in a hospital. So when the testing station is infected, sometimes we had to close the hospital, whole building. So then there's some innovations and the invention of so-called drive-through testings. So around the nation, many drive-through testing stations are introduced as a mass scale of testing. And another very important and a big controversial issue, especially from a Europe or American perspective, is the very extensive and sometimes very aggressive tracing of contacts. So one of the reasons that Korea so far did not have any major lockdowns is that whenever there's a positive cases, there's a very aggressive tracing of contacts. So what shops, restaurants was visited, and what type of transportation was used. So, and this type of information is gathered and disseminated by the government. So for me, like every day, I got text messages sent by my district government. So today we have found this case, and this patient visited these areas around this time. So if you happen to be around that area, that time, please go to the testing station and get tested. So because, as you know, there's a huge socio-economic cost of lockdowns. So I think we have a choice. Option one, okay, complete lockdowns, and we don't have to worry about privacy issues. Another option Korea took so far is that no lockdowns, but very extensive tracing. I mean, Korea is almost like a cashless society. People purchase even the Starbucks coffee with credit card. All the public transportation, almost 100% people use credit card for the transportation. So you can, so when you check the credit card, you can easily find, I mean, where it was visited and what type of transportation. But especially in Korea, there's little controversy on this type of tracing of contracts, especially because about 5 years ago, around the time of the MERS crisis, there's a strong public support request that we should use this type of active tracing of contacts. But I fully understand that it might not be acceptable in some countries. So it should be, this kind of contact tracing should be based on a social consensus, especially in a democratic society. But so far in Korea, a very minority of people question the privacy issues in this type of contact tracing. But there's a very, this is very popular policy in a sense, in a public sector. So I think that's those three, as I said, governance, trust, accountability, plus very early and mass scale of testing, plus aggressive tracing of context. I think that is a major features of the health policy for COVID-19 in the case of Korea. Thank you.
Thank you, Dr. Kwan. That was fascinating. We will next move to Singapore, where we will ask Dr. Vernon Lee to provide a perspective. Dr. Lee is the Director for Communicable Diseases in the Singapore Ministry of Health and head of Singapore Armed Forces Biodefense Center. He has overseen much of Singapore's efforts in combating and preventing the outbreak of COVID-19 in the country. Dr. Lee, over to you.
To show a little epi curve of Singapore's outbreak. And you can see that initially we had some imported cases, mostly from Wuhan City and Hubei province in China, that had seeded some local transmission in the later part of January and February of 2020. And that was actually kept well under control by a strict regime which we had put in, which comprised of a comprehensive testing strategy. So essentially, we tested as many sort of suspect cases as possible. And for every case that we detected, we performed active case finding around that case through contact tracing. And we tested more individuals to uncover every single case that we could find. For all these cases, they were isolated in hospital. And for the other close contacts who were well, we quarantined them for 2 weeks and monitored their health. And if they were shown symptoms, we would then admit them to hospital for additional testing. So with that, we managed to ring fence and contain the outbreak relatively well. Now, fast forward to March, and this is where we had a lot of returning, mostly residents from countries across the world. There was no single country where received cases from. They were really occurring all around the world and quite in line with the global spread of COVID-19. And with this new sort of wave of imported cases, they ended up seeding quite a bit of local transmission. So you can see that there were quite a lot of local, both linked and unlinked cases, signifying some community spread. Although a number of cases is still relatively low compared to many other countries, that is cause for concern. We are still performing active case finding and contact tracing and quarantine around every single case. So on my next slide, you can see that on the left, the time to isolation or quarantine for an individual makes a big difference on the number of secondary cases that every case will generate. So the earlier you isolate the case or you quarantine contacts, you reduce the opportunity of spread. And you can see on the right, we have shown that our method has been quite effective in bringing down the time from isolation to quarantine from about 8 or 9 days initially round to about 2 to 4 days at this present moment. And this is because of a lot of testing, a lot of awareness among healthcare providers, and we have changed our case definition and surveillance definitions across time to adapt to the changing epidemic and epidemiology. These are 3 curves showing the effective reproduction number across time in Singapore. So whether you look at the imported cases on the left, local linked cases in the center, or local unlinked cases on the right, you can see that we have managed to keep the reproductive number below 1 for most of the time, save for a few blips when there was transmission due to several clusters. You can see that the majority of cases actually did not transmit to anyone else. So about 70 to 80% did not transmit to anyone else. And this is due to early quarantine or isolation of those individuals. But unfortunately, some individuals do transmit to many secondary cases due to either their late detection or because they had either got to work or to social activities while they were ill. But overall, we have managed to keep the reproductive number below 1, which is what will take to reduce the outbreak and the force of infection. Now, of course, this excludes the number of cases that we are importing or that we had imported into Singapore. So this is something that we have to address moving forward. The other thing that we are, of course, concerned about is pre-symptomatic transmission. And this is some graphs from an article that we had just published in the US CDC journal, MMWR, showing that pre-symptomatic transmission had been detected across several clusters. So this means that in addition to sort of contact tracing, quarantine of individuals, some form of physical distancing and reduction of contact between individuals is also important in trying to control this epidemic. And finally, coming to the actual measures that we have rolled out in Singapore. So our measures are based on sort of risk-calibrated policies that are commensurate and proportional to the actual risk that we are facing. So as a baseline, what we have done, and we think that this is sustainable for long periods and will very well be the new normal, is to encourage individuals to have good personal hygiene and to be socially responsible to stay at home when unwell. So these are educational messages that we have put out to the public to empower them to do something, which is to take care of their personal hygiene and their own health, and to protect others, including their family and their loved ones. Now, between that and the other sort of policies which increase in terms of the reduction in the reproductive number, but of course are more disruptive, it depends on the situation that we're facing, the number of cases, what we anticipate the cases will look like over the next few weeks, and we have rolled out these measures in response to that. Now, we always try to stay ahead of the curve or ahead of the virus in Singapore. So instead of responding or reacting to the current available information, which unfortunately is always a lag. So by the time you see cases appearing today, they were actually last week's cases. So we have worked with modelers and other experts to try to project what might happen over the next couple of weeks if we do not do anything. And therefore, a lot of our actions are anticipatory in advance of what might be happening in the few sort of coming weeks. So we have moved, for example, to initially capping the size of events, telecommuting, enhanced measures for vulnerable groups such as the elderly, to subsequently suspension of events and entertainment, and limiting the size of gatherings to 10 or less people. And this is really to slow the pace of spread, preventing large clusters, and also to prevent the accelerated spread of disease. But now, because we are detecting more clusters and are concerned about sort of further spread, we have, in fact, today just announced that we will now do home-based learning for schools for the next over the next month, and will also allow only essential service, essential work to continue, while encouraging businesses to perform telecommuting. Now, this is not in response to any widespread community transmission in Singapore at this point, but we think that due to the large number of imports that we have received and the growing sort of outbreak, we think that this will help to bring the number of cases down substantially, as shown by the R0 earlier. And then we can balance that by sort of moving between these different policies in response to the situation. So it's almost like a dance where we move across the different policies across time. And we think that by doing this, it will be sustainable, because this certainly is not a sprint over the next month. It's a marathon that we do not know how long it will last. So this is something that we think will be sustainable, not just for the healthcare system to avoid any sort of a resources issues, but also to allow for society and the economy to have that sort of balance. Because if you do too little, the virus will overtake you very quickly. But if you do too much, then the cure might be more deadly than the virus itself. So we try to do this sort of balance to be proportional and in response to the actual risk. So thank you so much.
Thank you very much, Dr. Lee. We would now like to turn to Dr. Kenji Shibuya, who is the Professor and Chair of Global Health Policy at the University of Tokyo's Graduate School of Medicine. He is also the President of Japan's Institute for Global Health. He has analyzed the course of COVID-19's outbreak in Japan and published a paper recently in The Lancet analyzing the resilience of high-performing health systems, such as Japan's, against COVID-19. Dr. Shibuya, over to you.
Thanks very much. Actually, I moved to London, and I'm currently working at the King's College London. But today and yesterday, Japan is in the situation of discussing whether we should implement lockdown right now, because Japan's Tokyo situation is becoming very close to that in New York 2 weeks ago. So we are in the middle of a heated debate right now. But let me just share with you 3 major lessons from Japanese experiences in terms of COVID. One is, as you know, 2 previous speakers mentioned, I think it's possible to contain the outbreak, at least in the short term, with the very basic strategy. that is test and isolate. So very basic strategy did work, at least in the short run. But in the long run, it may be very tough. It becomes a trade-off between social, economic, and political element versus health impact. So, the containment could be easily damaged by politics and policies, both domestically and globally. So without concerted effort, it is not necessarily sustainable. Now, finally, I think it is extremely important to share information and joint learning process as we are doing right now. It is extremely vital to share lessons. So let me just start from Japanese experience in the early phase. So we published our colleagues with in Singapore, Hong Kong, about the resilience of health systems in high-performing health system countries. And we identify 3 major issues out of this. So initially, 3 countries did very well in terms of test and isolate and focusing on clusters of infected people. But I think 3 major lessons from these early phase experiences is threefold. First is that the integration of services in the health system and across other sectors amplifies the ability to absorb and adapt the shock. The second is the spread of fake news and misinformation constitutes a major unresolvable challenge. And thirdly, and finally, the trust of patient, healthcare professionals, and society as a whole in government is of paramount importance for meeting healthcare crisis. So that was still ongoing, but after the first phase, Japan didn't do well, particularly on the huge cruise ship Diamond Princess instance, which was a really kind of disaster because 4,000 crew members and passengers, and it was quite chaotic. But if we look at what Japan did in terms of domestic infection control, at the beginning, as Singapore did, and of course South Korea did, we are primarily focusing on the cluster-based approach, basically test and isolate. But what we didn't do well was we didn't expand the test capacity as much as we could, as suggested by Suman. And testing capacity was not enough to test all the suspect cases. We primarily focused on the cluster-based approach, and which was quite successful on the ground. But up to some extent, of course, it is extremely difficult to identify undetected cases. So until a couple of weeks ago, Japan remained, the cases, reported cases in Japan remained low. And people are really puzzled by that. But there are 2 possible explanations. One is Japan did well, actually focusing on clusters and basically test and isolate. But the other explanation is that there were cases which were not detected because of limited testing capacity. And both are reasonable. And I predicted that Japan would soon see the explosion from the undetected cases. And that is happening right now. And if, test and isolate strategy is a very classic, basic, fundamental public health approach. And I think WHO has been advocating from the beginning, right? But some, I don't know why, but many countries didn't follow or even ignore and follow their own policy interventions. For example, because we are constrained by the Tokyo Olympics until the end of last month. And Prime Minister Abe, all of a sudden, the cabinet decided to close all the schools, even at the very early phase of the pandemic outbreak in Japan, because there are very few cases among kids. And we are doing well on the cluster-based approach. Yeah. But all of a sudden, politicians went for that kind of symbolic, visible, very hard intervention. Then after a few months, the expert panel suggested to lift it, even though the outbreak was kind of expanding. So that kind of conflicting message from the policymakers, expert, was very confusing. And right now, both expert and MPs, particularly Tokyo governor, is asking the Prime Minister to announce the state of emergency right now. Otherwise, we will see the explosion. But still, there is a tension between Tokyo governor and the Prime Minister, partly because their incentive is slightly different. So the cabinet is focusing more on the social economic turmoil. On the other, Tokyo governor, requested by Japan Medical Association and Tokyo Medical Association on the potential collapse of the healthcare. So as Suman clearly mentioned, there is clearly a trade-off. And in the short run, we can just lock down for a couple of weeks and they lift it and they go back to another lockdown. We could continue a while, but afterward, in the long run, it's quite tough. So we need to adopt some sort of new social system and a way to adopt or renew, or as you first mentioned, reform our social and health and economic system. We really need to adapt ourselves to the new social system. So that will be clearly the next step. Right now we are focusing on tackling the pandemic or clusters or isolate the patient. And of course, we need to prevent the collapse of health systems. But given this, pandemic phase, I don't know how long it will take for the next couple of years. So we may need to seek the exit strategy and then also think about to adopt a new health and social economic systems, not just domestically, but also globally. And on that, we need to seriously look at some leading agency concerted efforts globally, because right now, even in Japan, lots of policymakers are criticizing WHO. Some mentioned that we are easily get caught by scapegoating somebody. But that's not helpful because WHO and other nation states are part of the solution. So I think it's the time to go back to the basics and to reinvigorate the global concerted effort. Or even though right now, or each member state, each countries, of course, have to tackle their own outbreaks. But inevitably, we may need to go back to the basics. Thank you.
Thank you, Dr. Shibuya. I appreciated the candor of your comments. We will now turn to Dr. Shui Lan, who is the Cheng Kong Chair, Distinguished Professor, and Dean of the Schwarzman College at Tsinghua University. He has been analyzing challenges presented by COVID-19 outbreak in China and strategies and the efficacy of Chinese policies in the public health response. Dr. Shui Lan, over to you.
Hello, can you hear me? Okay. Let me share the screen. Okay. I would like to first of all, just to give a very brief overview of China's response to COVID-19, and then I'll have some general reflections on how in a way to review, the challenges in managing this crisis. I think, of course, we all know that it started in Wuhan, China. So I think the first stage, in China's response is to really make sense of the risk. I think they started from the identifying the risk and trying to make sense of it. I think as we now know that actually in early December, the first case actually was patient went to the hospital. And then I think on December the 27th, Dr. Zhang Jixian reported the case through the infectious disease control system. So Wuhan began to conduct investigation. I think on the second stage of, in this making sense, is actually, I think that was partly was, led by the cover-up of the local health authority, and partly also, I think, was the not as rigorous as possible the process of investigating the cases that led to the wrong judgment that the human-to-human transmission was, either no cases or low probabilities. I think only by January the 20th, then I think the third group of the high-level expert committee, and they, actually they found indeed actually there was human-to-human transmission, and so I think that that was publicly, confirmed at a TV interview, and then I think that there was national, action. State Council enacted the law on infectious disease for COVID-19, and National Health Commission began to publicly announce the new cases. I think the Hubei also initiated level 2 public health emergency response, and Wuhan announced the lockdown of the city and began to respond to the increasing number of infected patients. So this, in a way, is a very hasty response, from the January the 20th to the early February. I think some of my colleagues have already mentioned that indeed testing and isolation is a critical step. However, testing at early stage became a bottleneck. And also, of course, I think because of the surge of the patients, medical beds also became limited. And so actually a lot of the patients or the people who are suspicious of themselves, being infected, they rush to try to get tested. And actually that act itself have further exacerbated the situation. So actually many people may have been infected through the mingling with those actually being infected. So this is quite a hasty response. The third stage is the national mobilization. I think actually the response outside Wuhan was very quick. I think the 3 provinces initiated level 1, the highest public health emergency response, on January the 23rd, the same day when Wuhan announced its lockdown. Also, the central government set up a leading group on January the 25th, and also established a joint containment and control working mechanism. And very quickly, 31 provinces started level 1 response for public health events. And also, I think the National Health Commission also published 7 editions of the COVID-19 containment, the treatment plan, and also 6th edition of control work plan. And also there's a national mobilization of medical doctors and nurses nationwide to support Wuhan and Hubei. At its peak, there were over 40,000 medical professionals from all over the country to working in Hubei. And of course, also there's a national mobilization to meet the surge demand for masks and other medical supplies and equipment. So this third stage is really a national mobilization to try to contain the virus. I think these are some of the strategies that was adopted by various local government and also the central government to contain the spread of the virus. The fourth stage is really sort of balancing act. I think this started in late April until now. I think that, first of all, I think starting on February the 23rd, there's a national televised meeting with Xi Jinping and all the top national leaders attending the meeting, along with 170,000 local government officials. This is the first event of its kind. I think basically at this meeting that there was and the government basically felt there was a good control of the spread, and then began to shift the strategy to a more sort of balancing act between the containment of the COVID-19 and also trying to resume economic and social activities. So that's sort of one set of sort of balancing act. I think most recently, I think there's another balancing act, being between how to control the resurgence of the COVID-19 locally, but also to control the importation of cases from overseas. So what are the challenges in managing a crisis like this one? The first one is how to make sense of the potential risks. I think this, the COVID-19 is a sort of really so novel virus that actually early on, I think there was really, some, difficult to judge its behavior and so on. So I think that sort of led to the mistakes that we saw. So I think that that state is always, I think, a very challenging in situations like this. And the second one is how to make decisions with great uncertainties. I think many of my colleagues have already said that we do have some, very effective strategies to contain the spread of the virus, but at the same time, that may entail very huge economic and social costs. So particularly when you are not quite sure of the behavior of the virus and, how to make those decisions are not easy. And the third is that, at least from what these various studies we've seen, the best way is to move ahead of the curve. So actually that to avoid, to avoid the peak, the high peak of the infected cases. But here, I think that it may not easy to do that, because I think the general public may not see that the need for that. So the general public's trust and cooperation is very critical. The next one is how to mobilize surge capacity to meet the peak demand. I think, when you have a crisis like this, there's always a special need for certain kind of resources. So how to mobilize the resources to meet the demand, I think that's really a critical challenge. So here the scale really matters. The next one is how to synchronize policies in different regions in a big country like China. I think that, of course, the central government always wanted to have a policy that can be implemented nationwide. But at the same time, how can you allow different regions to have varied policy, but also synchronized policies to reduce the potential cost? So that's sort of the challenge we face. I think now if we look, using those kind of measures to look at what China did, I think first of all, I think on the how to make sense of the risks, I think the Chinese public health system failed to recognize the risk fast enough to contain the virus. So I think that there's a very vibrant discussion about the weakness in Chinese public health system and the how to remedy it, and as what John Allen has mentioned at the early the opening of this discussion. The second is how to make decisions with great uncertainties. I think here the central government has acted very decisively and very quickly to mobilize the whole country to respond. So I think that the decision was made very quickly. The third is how to make moves ahead of the curve. I think here that one can say that I think the most recent study have shown that with Wuhan's lockdown, you can see that actually with lockdown and also with level 1 response, the lowest curve, that black curve, was the one that actually the outcome. But without that, without shutdown and without level 1 response, the red line would be the case. So that would have been much worse than what we have now. So I think that in a way we can say that China partially in a way was lucky because it's a spring festival holiday. So the lockdown actually, and also in Wuhan, and also I think the kind of policy measures taken to contain the virus was able to do that. I think was the timing was also important. Another thing is also the general public are quite cooperative, in following the measure. I was really almost so laughing at my Korean colleagues about the masks. I also had the similar things that, particularly in open space, sometimes I don't want to wear the masks, and my colleagues, people around, and they would often, tell me to wear masks. So I think that the general public are quite, cooperative in those in following the policies. And in terms of how to synchronize policies in different regions, I think China's this time has done a much better job compared to the last time when that H1N1. I think there is a much more stiff policy, and now I think this is a much more agile policy. And finally, in terms of how to mobilize surge capacity to meet the peak demand, I think at early stage it's very challenging in doing that. But I think later on, I think that was able to meet the demand. So I think that's a brief overview and reflection of the situation. Thank you.
Dr. Shui-Lan, thank you very much for your overview, for your reflections, and for your candor about some of the experiences and lessons that are being learned. We're truly grateful for your comments. You provided a perspective from Beijing. I would like to now ask Dr. Zheng Junhua to provide a perspective from the front lines. Dr. Zheng Junhua recently returned to Shanghai after 68 days and nights in Hubei province, where he was part of a team that worked on the front lines battling the pandemic. He also is the vice director of Shanghai General Hospital, affiliated to Shanghai Jiaotong University. He and his team have performed a lot of work over an extended period of time. He will provide a presentation, and he will also have some comments that may be interpreted consecutively by translation. Dr. Zheng, over to you. Thank you.
For my PowerPoint, can be on.
Distinguished professors, good afternoon, China. Good morning, America. At the critical moment of the global fight against novel coronavirus pneumonia, I would like to participate in the discussion meeting on how Asian countries control the novel coronavirus pneumonia network sponsored by the China Center of the Brookings Institution, and share the experiences and summaries from Wuhan, China. Next, I will briefly introduce the situation of our medical team. The first batch of medical teams in Shanghai are composed of 135 people from 52 units, with 37 doctors, 93 nurses, and 5 hospital flu. He arrived in Wuhan at 1:30 a.m. on January 25th. The first of the national medical team to arrive in Wuhan on the afternoon of January 25th. He entered Wuhan Jingyantan Hospital to take over the work of the second and third floor. On March 13th, 2020, JAMA Internal Medicine, the well-known international medical journal, published online a joint clinical analysis of JAMA internal medicine by the first batch of Shanghai medical teams led by Professor Zhang Jianghua and Professor Song Yuanlin of Wuhan Jinyutan Hospital and Zhongshan Hospital affiliated to Fudan University. This study reveals the risk factors for the development of acute respiratory distress syndrome ARD. Studies have reported the clinical features of COVID-19, for example. Juan et al. First reported that the common clinical manifestations of COVID-19 patients included fever, myalgia or fatigue, and dry cough. Current clinical practice suggests that most patients have a good prognosis. But older patients and patients with chronic underlying disease are more likely to have a poor prognosis subsequently. Cheng et al. The study highlights that advanced age is associated with an increased risk of developing ARDS and of progressing from ARDS to death. It was also found that although high fever was associated with the development of ARDS, it was associated with a reduced risk of death in patients with ARDS. The study also found that among patients with ARDS, 46.0% of 50 patients who received methylprednisolone died, compared with 61.8% of 34 patients who did not receive methylprednisolone, preliminarily suggesting that methylprednisolone may be associated with a lower risk of death from ARDS. The study highlights that advanced age is associated with an increased risk of developing ARDS and of progressing from ARDS to death. It was also found that although high fever was associated with the development of ARDS, it was associated with a reduced risk of death in patients with ARDS. Lead author Dr. Xiaomin Wu, from the Shanghai medical team, said, "This study has received a lot of attention from international colleagues, with at 134,750 of reading times a week."
Thank you. It was closed.
Hello, it appears that we have lost Dr. Zheng's presentation at the moment. So with that, I think we will move into the question phase, and I will turn it over to Suzanne.
Thank you so much, Ryan, and thank you, my profound thanks to all of the panelists that we've heard from today. Your remarks are so important and so informative, and I look forward to carrying on a discussion over the course of the next few moments, and then turning to our audience for some questions as well. Let me start with you, Dr. Kwon. South Korea's approach to tackling COVID-19 has been lauded as one of the quickest and most effective responses to the pandemic. As one of the earliest nations outside of China to be impacted by the novel coronavirus, how was South Korea able to be prepared so quickly? You talked a little bit in your presentation about past experiences. I'm wondering if that was a major factor and if there are other factors that you might point to in devising such an effective approach.
Thank you. I think that the policy learning from the past failure, failure of MERS crisis was a very important factor. From my view as a policy person, because at that time, it was a shocking failure within Korea. And there are a lot of discussions and current government at that time was the opposition party. So that at that time, the opposition party heavily criticized that government. And now this government, that opposition party becomes the current government. So I think this government is a bit, more progressive than the previous one. And this government has more keen in the overall health and social policy compared to the previous one, and learning from the past, as I mentioned, failure of MERS. So they moved very quickly. So I think that's a very important factor in terms of a policy learning perspective, learning from the past. But also, there's like a tested learning. We call policies some kind of learning by doing and tested learning. So in that perspective, also like innovative, some kind of innovations in terms of drive-through testings from the experience or learning by doing aspects. Yeah, that's my short response.
Thank you, Dr. Kwan. Dr. Lee, turning to you. Would you speak for a few moments about the biggest challenge that Singapore has faced and how you might be approaching the possibility of a second wave of COVID-19? You spoke about the schools shutting down, for example. Are there other measures that are being undertaken to insulate against the possibility of a second wave?
So I think the challenges are probably twofold. One is the importation of cases from countries where the outbreaks, of course, in a more advanced stage, and that's something that unfortunately we had to deal with because Singapore residents were returning from many countries across the world where COVID-19 outbreaks were increasing. So those returning individuals had seeded this sort of second wave of transmission that we have to deal with at the moment. Since then, because we now know a lot more about the epidemiology and the spread of disease in different countries, we have actually put in place a mandatory 14-day stay-at-home notice for all travelers from anywhere across the world coming to Singapore, and they would then have to basically remain in their place of residence or hotel for 14 days and not be in contact with anyone. So with that, with the recent returnees, we had actually reduced the spread of COVID-19 quite substantially. But of course, we have to deal with this, as you mentioned, second wave of community transmissions. And what we've done is to increase progressively, a suite of measures. And all this, like I mentioned earlier, is part of anticipating any future increases in cases, but also to do something to bring the number of cases down so that we would be able to balance between some of these higher intensity measures and to bring it down, and then we can move back more to life as usual as much as possible. So we try to do the set of measures that we think are most appropriate for that point in time, rather than trying to roll out things too early, because then you might have to hold them for a really long time with huge socioeconomic impact, or to do it too late and then the health impact would be very high because the outbreak can quickly go out of control. So it's this fine balance that we're trying to reach. So it includes things, for example, we're doing now like having home-based learning for school children, to encourage people to telecommute as much as possible so that we can reduce community interactions, and to ask people, especially those from the vulnerable groups, the elderly, those with comorbid medical conditions, to stay at home as much as possible. So all these measures we hope will be able to bring the reproductive number low enough so that we can really reduce cases in the next coming weeks. Thank you.
Thank you, Dr. Lee. Turning to Dr. Shibuya, we heard, and we have heard in a number of media reports, as well as most recently in Dr. Zhang's presentation, about the vulnerability of the elderly to COVID-19. Japan, like other countries that have been hard hit by this virus, has a very large elderly population. What measures has Japan undertaken to look after the health of this significant segment of the population, and how have they been so effective?
So you're absolutely right. So as we are Japan is one of the most aging society as Italy. So Japan is fully aware of the risk of the large number of potential severe cases. So all the hospitals, particularly intensive care unit, and also nursing care home, other places, the government has already informed the potential spread of the coronavirus, and also some measures. But I think we are still lagging behind in terms of preparedness. And obviously right now, given this current potential surge of the infection, all the municipality government, prefecture government are working around the clock to prepare for the next phase. And in terms of effectiveness, we are not quite sure at this stage because everything is a little bit chaotic. And the fundamental problem right now is the lack of proper communication, coordination, not just across the agency, but also between the expert and policymakers. It's becoming really tricky. And at the beginning, because we had our Tokyo Olympics, so the policymaker would like to keep the things calm down, and also they didn't want to share bad information, and also they wanted to show off that they're doing as much as they can, put aside all the technical and scientific evidence. But now we see the potential explosion, and including myself, lots of experts are warning the government, but still the government is very slow to act. So, and also that affects the public perception about this extent of pandemic. So all these factors are now becoming very, very complicated.
Thank you. Dr. Shui Lan, if I may, I'd like to ask a question or two of you. I've heard from others, not from you, that you've been invited in the past to brief the Chinese leadership on public health issues. Prior to the outbreak of COVID-19 in Wuhan, how prominent of an issue was pandemic control on the minds of China's leaders, and what concerns were foremost in consideration in Beijing?
Well, actually, I was indeed, I think last November, I did, gave a talk at the Central Politburo's study session on emergency management, not on public health per se. In talking about emergency management, we have four major kind of emergencies that was listed in terms of when we talk about emergency management. Public health is one of the four kinds. So I think that the government, the leaders do pay attention to how to build a strong and robust national emergency management system, including one, responding to public health events. So I think that in general, I think after China's, the SARS in 2003, the national leadership has indeed been paying great attention to address public health issue events like this one. So I think in 2009 when there's H1N1, and I think China did responded very quickly. This time also, I think that the response, once the problem is recognized, the response was very decisive and very quick. But I think the challenge is how do you recognize the problem early enough? That's the challenge.
Thank you. And can I just pick up on that thread, because there's been a lot of discussion and focus about the issue of transparency, and you raised it in your comments as well. It's a difficult challenge. What do you anticipate will be the corrective measures taken to increase and enhance transparency at the onset of outbreaks in the future? And related to that, China has not publicly recorded asymptomatic patients until April 1st. Why did China make that decision not to publicly record those cases?
Okay, let me respond to the first one first. I think the question is not simply a transparency problem. I think this time again, I think it's a novel the virus. And I think when it first appeared, it's very difficult to recognize its behavior and to understand its behavior. So I think that wherever it happens, to appear, I think that process is going to be challenging. And here I think that if you look at the whole, I think now in China there's a lot of there's kind of reporting really outlining the whole sequence. You see that actually the local health authority indeed actually announced publicly about the appearance of so-called the unknown pneumonia. So I think that itself is not where they're trying to cover up. But I think there was certainly, I think there seems to be efforts by the local government to downplay the significance of the event, and also to I think they've also because of that downplay led to the sort of in a way the wrong judgment about the behavior of the virus. So I think that, but as you can see that as soon as the the behavior of the virus was recognized, I think actually there was very quickly a quick movement of the National Health Authority to report to the general public about the behavior, about the cases of the virus. I think on the second issue, I think actually if you check carefully of the January the 28th, I think there was a third edition of China's sort of containment plan of the COVID-19. They were already actually they were in a way including the sort of asymptomatic sort of cases in that plan. And so basically there was already being covered by that containment plan. And I think they're very careful sort of cases. How do you treat those cases? So I don't think there's any sort of intentional sort of in a way sort of cover up on those cases. I think actually those cases were indeed covered in that edition. There were already indeed they were found. There were cases that people were infected, but there was no symptom. So if you read the control plan of the January to 28th, and that was already notified, and also that was measures being taken. However, that was not separated from other sort of cases that's being observed or being quarantined. I think now, given that there's so much discussion and public's concern, so I think now on April the 1st, the government began to take that group in as a separate group. But again, there was nothing new, but it was just from the previously quarantined cases, and this taking them as a separate group. So I think that's if people read the version 3, that should be quite clear.
Thank you, Dr. Shui.
Yeah.
Dr. Cheng, if I may ask you a question. As Shui Lan was just noting, this has been a novel experience. We've been learning a lot as we've been dealing with this crisis, both in China and Asia and around the world. As a medical professional and practitioner, what have we learned about protecting medical personnel dealing with this virus since the outbreak in Wuhan?
郑院长您好，像刚才薛兰教授提到的，我们现在面对的是一个新型的病毒。现在在中国、亚洲乃至世界上，我们都在了解更多关于这个病毒的新的信息。那么作为一个医疗的这个专业人士呢，想听听您讲一讲，就是说我们如何在抗疫的这个过程当中呢，能够更好的保护我们的医护人员。
目前的话呢，应该前段时间呢，在湖北呢有386支4万多名的医护人员战斗在武汉和湖北。
So previously there were about 386 teams of medical professionals, and in total about 40,000 medical professionals fighting against the virus in Hubei.
到目前呢，已经撤回了3万多名队员。 将近4万名队员已经撤回了。
And close to 40,000, about more than 30,000, close to 40,000 of these medical professionals have returned to their homes.
目前得到的数据呢是医务人员原额的医疗队没有一个人感染。
So the current figure shows that out of these 40,000 medical workers who went to help Hubei province, the infection rate was 0.
据我所知的话呢，只有1名医务人员车祸牺牲，1名医务人员过度疲劳、心脏骤停还在继续治疗中，1名医务人员的脑血管意外，在手术后康复过程中。
Well, according to my knowledge, one healthcare worker unfortunately died from a car accident. One suffered from a heart attack due to long hours of labor, but currently under treatment. And another one suffered from a cerebral vascular accident and now is under recovery.
Thank you. And if I
这
may,
系统、消化系统和心血管系统。
Well, and of course, among the frontline healthcare workers, common medical problems in respiratory systems, digestive system, cardiovascular system do occur.
那我们是怎么做的来保证这样的零感染？希望呢，我们的经验呢，对大家有借鉴作用。
So I would like to share our experiences of how do we achieve the number 0. I hope our experiences can be helpful to others.
我们将医疗队分成了医疗组、护理组、后勤组、疾控组、检验组、院感组和心理指导组、宣传组等8个小组，并建立了医疗队的管理制度和队员的守则。
So we split the medical team up into several groups, including a treatment group, a nursing group, a quality control group, a testing group, a hospital infection control group, a psychological consulting group, and a publicity group. In total, about 8 groups. And we established a medical management system and also a code of conduct for all team members.
我们制定了包括院内感染的管理制度、物资的发放规定、使用规定、休息室的管理规定、驻地酒店的防护规定、手机终端末端设备使用规定在内的6个管理的原则。
So the system we established includes a code of conduct, a hospital infection management system, a medical resource distribution and application rules, and public launch and space management system, and the destination hotel protection and prevention rules, cell phone and mobile device usage rules. So all in all, about 6 sets of rules and regulations.
我们把院杠放长在重中之重。 我们还制定了一套针对职业暴露的预案，例如扎针时护士扎到自己的手指，防护衣被勾破了，防护衣不小心污染等意外的突发情况，该如何的处理？
So we've always focused on how do we prevent infection among our healthcare workers. So we have also made a set of contingency plans for occupational exposure. Such as what happens when a nurse accidentally punctures herself during an injection, what happens when the protection gown is damaged, what happens when there's contamination when someone is taking off the protection gown, and so on.
Great. Thank you very much for sharing those insights with us. Given the shortening time that we have together and the abundance of questions that we've received from around the world, I'd like to now turn to a few questions from the public. We will start out with a question from Mark in Washington, D.C. The question is directed at Dr. Kwan, but others are welcome to jump in from, particularly from a Japanese or Singapore perspective. But after the infectious disease management law in January or February was put in place, was there a sunset period for when the law would be revoked? Are there limitations on what information the government can collect and disseminate publicly? And how long is private information kept by the government? Dr. Kwan, why don't we start with you, and then if others would like to jump in, they're welcome to as well.
I'm very sorry, but it is about information. I didn't get it very clearly, the answer. I mean, the question.
It's a question relating to the infectious disease management law and whether or not the law would have a sunset clause. So in other words, once the disease has passed or the pandemic has passed, will the law be withdrawn? And what are some of the practical effects of the law on information collection and privacy issues?
I see. I'm sorry, but I'm not very familiar with this law, but still, as I mentioned, there is a clash or trade-off between privacy issues and especially the collecting the information related to the tracking of the context. But as I mentioned, at the very beginning, some people raised issues of these privacy issues, but overall, I think people tend to accept this potential violation of privacy. And then that's my very brief answer, but I'm not sure whether I get the question very correctly, sorry.
Okay.
And also, another very important information source is that we have a national health insurance covering everybody. So whoever used the healthcare visited clinics or hospitals or even pharmacy, most of the informations are all collected by the one single payer, National Health Insurance System. So even that information is quite extensively used in the tracing of context. So there is another very important information source, single payer covering everybody.
Thank you. Our next question is from Yu Xuan in the University of Oxford for Dr. Lee in Singapore. The Singapore government indicated recently that when the virus containment reaches a better situation, border control measures may be relaxed. What factors are currently under consideration that would drive a determination on relaxation of border control measures?
Sure, I think that will depend on several factors which we have to take in as a whole. Of course, is what the sort of global situation is like, and what the situation in perhaps specific countries where we would want to relax those measures might be, and that would include things like how comprehensive surveillance systems are, what is the overall number of cases and the trajectory of the outbreak, both in Singapore and in the respective countries. But I think that is something that we would have to consider, so that that there is an end stage to this whole sort of containment efforts, because I think right now a lot of governments and international organizations alike are looking at when these containment measures will end and how they will end. And I think even within countries, like I think your earlier question about how long these measures will be put in place. I think most governments at the moment, including Singapore, when we come out with a measure, we will say we will put it in place for a certain duration. And typically we will say, I think 2 incubation periods or about 28 days to a month is a reasonable period where we can then observe whether there is any impact of those measures, and then we can adjust accordingly. I think it needs to be something that's in a way time bound or time limited, and then you can consider adjustments, because if you leave it totally open-ended, the danger is that there's always a risk that you would keep it for longer than they are necessary. So I think these are some of the factors that we would consider.
Thank you, Dr. Lee. I have a question from Hannah for Dr. Shibuya. The question is, why has the number of cases and mortality rate in Japan been so low relative to other countries, especially in spite of the lack of preventive measures that have been instituted by the government?
So first of all, as I said earlier, Japan focused on the targeting clusters of infected people. at the beginning of our control measure, and which has been successful. So, and also the other flip side of the coin is that we didn't do aggressively in terms of testing, expand testing capacity. So both contributed to a relatively low number of cases up to now. But now in Tokyo and the big cities like Osaka, we see the rapid increase in number of reported cases. So we now see, we predicted there will be an explosion, and we are entering the second phase of this pandemic situation. In terms of number of deaths, because we have so many pneumonia deaths, so there will be misclassification, but also we were in the early stage of this outbreak, so we will see more potential casualty in due course.
Thank you. I have a question from Dr. Francis Liu. I will direct it to Dr. Shui-Lan and Dr. Cheng. It's a question about face masks and wearing them. And I know that Shui-Lan, you spoke about this as well as Dr. Kwan. This is a subject of some debate in the United States, whether there should be more encouragement or instruction for people to wear face masks. How critical has the use of face masks been? And should there be more pressure on the general public to wear face masks in public?
Let me first say a few words. I think then, of course, Dr. Cheng probably is more authoritative on this issue. I think, first of all, I think that based on the findings so far, I think there seems to be, I think that, face masks would be very helpful in terms of, preventing getting infected in sort of closed, sort of spaces like in elevator or in crowded places and so on. So that actually, I think, certainly, given what's been known, that should be useful. But at the same time, if you're in a open space at the park, that may not be as necessary. That's my understanding based on what I see. Maybe Dr. Cheng can also tell us more.
Thank you.
郑院长你好，下面一个问题是给您的，就是说呢，想让您跟大家谈一谈，您认为戴口罩，作为一种公众的防护的方法，有多大的重要性和有效性？那么政府呢，是不是应该更加鼓励和给公众施压，鼓励公众呢在公众场合佩戴口罩？请您点评一下。
从目前对冠状新冠病毒的了解来说，它还是一个主要经呼吸道传播的疾病。从我们的尸体解剖的情况来说的话，也是对肺部的损伤作用是最主要的，所以目前认为还是从呼吸道传染为主的一个疾病。
So, according to our knowledge of the COVID-19 so far, it is a respiratory disease, and according to the results of the autopsies, the major damage to the human body was to a person's lungs. So right now, we mostly look at it as a respiratory disease.
所以从这些道理来讲的话，戴口罩的预防作用非常的重要。
So from these conclusions we've drawn so far, I believe wearing a mask is a very important preventive measure.
在目前的国际的疫情的情况下面，特别是在流行的国家里面，大流行的国家里面，我认为强制性的在公共场所进行戴口罩是非常必要的。
So according to the situation of the widespread of the coronavirus internationally, and especially in the countries with major outbreaks, I believe it is very important that the government should put forward mandatory requirements for people to wear masks in public spaces.
我们建议呢，在公共场所戴的口罩呢，是以外科口罩为主，不需要 N95 的口罩。
We believe for the general public, the masks that they wear in public spaces should only be surgical masks and not N95 masks.
我们也建议呢，在公共的活动要减少，特别是群聚性的活动应该尽量的减少。如果是疫情发生严重的地方，可能要采取更严格的措施。
And we strongly suggest that we should try to decrease the amount of activity in public places as much as possible, and especially with group of activities. And also in places where the outbreak is really surging right now, maybe you need stricter rules.
我们还是建议把更专业的口罩留给一线接触的医务人员。
And we also recommend that we leave the professional face masks for our frontline medical workers.
That's all.
Thank you very much. If I could ask one final question, we're out of time, but it's a yes or no question. Is there any evidence of neurological issues associated with the virus?
我想最后问一个问题，就是在这个病毒方面，我们有看到一些这个神经医学方面的这个证据吗？
目前有关神经方面的损伤还不明确。我们自尸检的材料过程中，对脑组织的损伤不重，但是我们在临床过程中呢，也发现了到一些神经末梢的改变，比如说我们有发现有短暂的病人的失眠的情况，也就是眼睛看不见了。经过抗病毒治疗以后，肺部炎症减退以后，它就消失了。那么我们在判断一是不是病毒引起的，二是不是由于血管阻塞引起的，那么目前还没有完全的明确。
So in terms of its neurological impact, we're still finding out more evidence, and it's very hard to draw a conclusive conclusion right now. According to our clinical evidence and also from autopsies, we found out that it's mostly damage to the lungs, and it's very little damage to the brain tissues. And also, but also during the clinical experiences, we have found that some patients might lose their eyesight temporarily, but with the improvement of their lung function, their eyesight might improve. So we're still trying to see whether this temporary loss of eyesight is caused by virus or is caused by conglomeration in a clot in their blood vessels. We're still finding out.
Thank you very much. We have many more questions, and I have many more questions, but I'm afraid that we've run out of time. I want, on behalf of Suzanne and myself, to thank you deeply for the wisdom that you've shared with us, the perspectives, the lessons, which I hope will be beneficial not just in the United States, but around the world. And with that, I will turn it over to my colleague and friend, Cheng Li.
Hello, could you hear me? Well, thank you, Ryan. And I'm Cheng Li, Director of Brookings John L. Thornton China Center. I'm honored and humbled to moderate today's second panel. Before introducing the next group of speakers, I want to convey my heartfelt appreciation to the terrific speakers on the first panel. Your expert insights and professional dedication have been vital services to your respective nations, and indeed in the service of all nations. At this historical moment, the biggest humanitarian emergency of our lifetimes. The international community will surely benefit from the responses and the lessons of your countries. Now, our second panel is less country specific and more focused on prevention, treatment, and forecasting of the corona epidemic. We are so fortunate to feature three leading experts on these topics. The first speaker is Dr. David Ho, a Taiwan-born American scientist who is the founding scientific director of the Aaron Diamond AIDS Research Center in New York City. As many know, since the 1980s, 75 million people around the world have been infected with HIV. Of those, 32 million have tragically died. The rest have survived thanks to the remarkable antiviral therapy known as the AIDS cocktail, which was first developed by Dr. Ho in the middle 1990s. In 1996, Dr. Ho was named Time Magazine's Person of the Year.
The masks that they wear in public spaces
should only be surgical masks and not
Please
N95.
turn off their voice. Now, just as David Ho is a household name across the United States, our next speaker, Dr. Zhang Wenhong, is a household name in China. Dr. Zhang is professor and head of the Center for Infectious Disease at the Huashan Hospital of Fudan University. Since the early days of the coronavirus outbreak, Dr. Zhang has served as the head of the experts team for medical treatment of coronavirus patients in Shanghai. He has emerged as a leading expert on prevention and the treatment of the virus. He has earned substantial media praise in China, perhaps next only to Zhong Nanshan, another legendary figure in China's battle with SARS in 2003 and the coronavirus now. Last but not least, Dr. Cheng Jian is the founder and the president of CreditWise Technologies, trained in engineering, computer science, and mathematical modeling in both China and United States. Dr. Cheng's specialization includes application of state transition metrics modeling to infectious diseases. Since the coronavirus outbreak, he has worked very closely with many leading scientists and doctors in the field, including both Dr. Zheng Junhua from the previous panel and Dr. Zhang Wenhong on this panel. Dr. Cheng provides timely data analysis and matrix forecasting on crucial issues like infection peak time, patient distribution, and mortality rate in various locations. Please join me in giving a warm virtual welcome to our three outstanding panelists. Now let me turn to the first speaker, Dr. David Ho. Over to you.
Thank you very much, Li Chen. It's a pleasure to participate in this online symposium. I think everyone knows that the global pandemic now has infected over 1 million individuals with 55,000 deaths worldwide. And the United States now account for about a quarter of the caseload and accounting for over 10% of the deaths. And we're still in the upswing of this particular epidemic. I just want to give you a view of the situation here in New York State and New York City in particular. Yesterday in New York State, we had approximately 9,000 new cases. So we are the new Hubei, and we're not even done with the epidemic yet. In New York City, yesterday, we reported 5,000 new cases. And so we are the new Wuhan, and the numbers are still continuing. And it's hard to believe that it was only 1 month ago that we saw our first case. Now in the hospital outside my window, 5 floors of a major tertiary referral hospital is taken over by COVID patients. Our hospital has become an ICU hospital to a large extent. Almost all the usual ICUs are now occupied by severe COVID cases. And we have not even reached the peak. Let me just tell you that of the swabs that are coming from the nose or throat submitted for PCR testing, about 2/3 of them are positive. Of course, this is a reflection of the inadequate testing, and testing is preferentially administered to the sickest patients. But it is very difficult to imagine what's going on in the hospital here. We have carnage that's unprecedented. Now, in the US, we are seeing wave after wave of infection hitting different regions, as you know. The first wave hit the West Coast, and New York followed shortly thereafter, with New York becoming the epicenter of the epidemic in this country. And this now is followed by waves sweeping through cities like Detroit, New Orleans, Chicago, and rest of Middle America. I think the problem is that many of the regions in the US are not proactive. They are only reactive when problems appear. The attitude seems to be that this is someone else's problem, but yet the virus spares no one. And my concern is that, let's say California, which was the first to implement more draconian measures to control the epidemic, let's say it flattened the curve in the course of the coming months or two, but its neighbors, Arizona, Nevada, and others, are still struggling with waves that occur much later. How is California going to relax given the freedom of movement that we have in this country? And if you, in essence, I think we need to apply this sort of thinking not only to the US, but to the world. If we continue to let a lot of countries treat it as if somebody else's problem, the world cannot open up because our neighbors will be struggling with the infection. And so in many ways, we need global leadership to compel the world that we apply the same measures in synchrony. We need to do that together. In essence, we need to endure together, flatten the curve simultaneously. In essence, somewhat similar to what China did in late part of January. Of course, hindsight is 2020, but if you imagine the world having implemented shelter in place in late January, this crisis would be largely under control now, with a good chance for extinction. But that's not where we are. And yet there are too many places that are still treating it with great deal of complacency, thinking they would be spared. As I said earlier, the virus will spare no one when it comes in contact with a particular individual who's not immune. So I think there's a lot of talk about flattening the curve and avoiding the surge that will overwhelm healthcare systems. And that we must do. And it's being applied in many, many places. And hopefully a healthcare system that could absorb the surge of patients would manage to support patients better and have a much lower mortality rate. One thing we need to keep in mind though, is that spreading out, flattening the curve means we're spreading out the infection over time, but the cases will continue to accumulate. So we need to extend that flat curve out much, much longer because the cases will build up unless science delivers a solution to treat or to prevent infection. And so I think for the foreseeable future, we have to plan on not seeing much of a scientific solution for the next year and perhaps two. Now there's a lot of talk about repurposing drugs that are already available and have already been tested in humans for other purposes. And yes, that we must do. And that already has been done to a large extent in China and Europe and now beginning in the US. These drugs, some of them decrease inflammation, some of them treat the virus. But from the data that are available now, at best, they're going to be only temporary solutions. We need to launch a global effort to find new drugs, antibodies, and vaccines that are optimal for this virus, but also for this lineage of beta coronaviruses, because the next pandemic may not be exactly this virus or exactly the SARS coronavirus. So let me just tell you that from this, as a working scientist, on this front, I'm inspired and I'm awed by what the scientific community has done. It has mobilized in a way that I have never seen before. A lot of laboratories have to shut down if they're not addressing the COVID outbreak, but some of them have very rapidly shifted to work on this problem, contributing some in mundane ways and some with very special ideas. And I will just tell you, there are already hits in the laboratory for new drugs that block certain enzymes of the virus, protease, polymerase. There are already antibodies that have been identified that could neutralize the virus and perhaps be used as either a therapeutic or a prophylactic. And we know that there are already vaccine candidates being developed by at least 20 companies, if not more. And several of them are either in the clinic already or will soon be in the clinic. And same with the drugs and antibody hits, those have been slated for entry into human testing within the next few months. So this is really unprecedented. However, starting testing doesn't mean they will be immediately available to address the pandemic, because the process of testing for safety animal, putting it into manufacturing, then with the manufactured product, you have to further test it for safety in animals, and then begin a series of human clinical trials, starting with phase 1, slowly with a few people, and then enlarging those studies to include more people and for longer duration of follow-up. So you could see this process of product development will take quite a bit of time, certainly more than a year, and if not 2 years. So we are contracting the process from typical 5 to 10 year drug development timeline and trying to contract that at least 5-fold, if not 10-fold. So that's what we're confronted with. But in the long run, I'm confident that science will provide a solution given the dedication now put in, not just by the healthcare workers, but by the basic scientists who are trying to find permanent solutions. So let me leave it there. And thank you, Li Chen, for the chance to talk.
But also hopeful remarks. We will certainly ask you questions. A lot of audience already sent questions. So we go to next speaker, Dr. Zhang Wenhong, please.
Yeah, Li Chen, glad to meet you. And I'm honored today to be here, that have the chance to discuss this epidemic with Professor Hu together. And it's a good chance for me to share the Shanghai experience with the scientists and the clinicians around the world. So first of all, I just want to share some experience in our city, the big city with almost 30 million people, and in China, the experience both from Wuhan and Shanghai, totally different situation. So the Wuhan stand for a city with the outbreak of the disease, and in Shanghai, a big city with imported cases. So first of all, I just want to share some experience of Shanghai. Firstly, the first case of COVID reported in Shanghai was January 20th this year, and it is an imported case from Wuhan. And after 2 days later, the Wuhan announced its lockdown, and I think it's a good chance for us that stop the imported case from the epicenter in China. So several days later, Shanghai announced a top-level response to the major public health emergency. And we can see that after strong measures controlling the local transmission, and which help us to stop the spread of the disease. So Shanghai, in the end, stopped the spread of the disease very quickly. However, we can also observe that in the mid-March, the challenge for Shanghai now has turned to global imported cases. I think this is a second wave right now. I think this challenge is almost the same like other countries, just like Korea, Singapore, and I think the same challenge around the world. So today, lots of experience from other countries actually help us to face the challenge of the second wave in this plague. So actually, before we work for stopping the spread of the disease in Shanghai, one colleague from the United Kingdom, he published a paper. They showed the model that predicted Shanghai with 30 million people and lots of imported cases from Wuhan. They predicted that maybe almost 800,000 COVID cases will be in the end happen in Shanghai. And another model, they predicted that at least it should be 8,000 cases will be reported by mid-March. Actually, in the end, we just now only around 400 emerged in our city. So the key was the early control of the local transmission. I think this is the most important experience for us. The first case in Shanghai, like that in the United States, was identified on January 21 and 21st this year. At that time, Wuhan's lockdown suppressed most of the intercity traffic from Hubei province to Shanghai. Shanghai, in the meantime, immediately took aggressive measures to slow down the whole city, including canceling all gathering activities, suggesting all citizens to stay at home, I think these measures recently also taken by the United States. So meantime, it's very happen by us. We have the very long holiday in China. You know that it was a Spring Festival. So I think we were very lucky that we have a long duration to stay at home and without doing job outside. So furthermore, our city, the government extended the Spring Festival more than 10 days to 1 week more, thus allowing Shanghai's social distance to overlap the length of the 14-day incubation period of this disease. Therefore, if anyone really had a possible infection through intercalling and imported case, I think the time is fit. So our holidays. At the same time, although we stay at home, the city, so the grocery, supermarkets, hospital, banks, and other life necessary facilities remained open for the normal life. So you can see here, the Shanghai just slowed down, not lockdown. We keep our traffic, we keep our life necessity facilities, so everything remain normal. So I think this is a good tempo for us in the future. If we control the imported cases at a very early stage, we can keep our normal life and not lockdown. So after the outbreak, I think everything changed. So meanwhile, in our hospital, I worked in a comprehensive hospital with 2,000 beds. We do massive testing, and the Shanghai CDC, they traced every patient among suspected case. So, and now I will introduce to you how we optimizing diagnostic flow for COVID diagnosis. In Shanghai, we for almost a network of 100 120 fever clinics, and also we added more 180 fever sentinel hospitals. So this is a big network that will help us to find suspected patients. We do the test for every suspected patient we found without money. So everything is free. We do it very quickly. So this helps us to find the people timely and quarantine the suspected case and quarantine the close contacts. The timely diagnosis would lead to the timely quarantine and the breaking of the transmission chain in Shanghai. In fact, the timely diagnosis protocol and the timely quarantine measure in Shanghai effectively stopped the circulation of the COVID in the city. This activity did not cause overwhelming impact on the normal citizen's life because we quarantine every suspected case we found and no spreading of the disease in our community further. The incubation time we found that only in our city only 6 to 7 days, and the mean onset hospital admission interval was almost 5 to 6 days, so very short. So therefore, all those methods in the end lead to early control of the local transmission in the community. And this is the key to stop disease spreading. In Shanghai, we can see that after the original imported cases, the local transmission were quickly inhibited, and therefore, that led to the control and the prevention of the epidemics. The overall mortality rate, because we have just several hundred cases here in Shanghai, so we have enough medical resource to keep our critically ill patient well cared. Therefore, in Shanghai, our mortality rate of the patient only 1% in the end. So in the end, we concluded that the key points of the medical and the health control in Shanghai and China is that we found all suspected patients and tested them and at least twice by CDC. And so therefore we increased the sensitivity of the PCR to find the patients. All nucleic acids and the treatment are free in Shanghai. All diagnosed patients should be admitted to designated hospital, just like my colleague Junhua Cheng mentioned that in Shanghai, we gathered all power in our city together to treat the patient in the designated, because we only have almost 400 patients. So our medical resource recently, we know that it's very enough. If we have much more patients, I think our ICU beds is not enough. All the close contacts of the diagnosed patients, we traced and quarantined for 40 days, and all close contacts of the diagnosed patients will receive the RT-PCR test recently. So all these jobs are done by the CDC colleagues. So I think all my presentation today here, and I will thank for your attention. It's actually as Shanghai and China, we just went through a pretty dark moment but however, now the plague now still spreading in the world. I think we should work together to fight the disease. And I hope that the experience here today, I will study the experience from other countries to face our second wave. And our experience in the first wave, I think also can be shared by other countries. Thank you.
Thank you, Dr. Zhang. As a Shanghainese myself, I certainly admire and appreciate your wonderful work in this battle. And really thank you for sharing your insights, your experience. Now, next speaker is Dr. Cheng, please. Cheng.
Can you see my screen?
Yes, yes.
Okay, thank you. Thank you, Cheng, for this wonderful opportunity to share some of the modeling experience I've had with both Dr. Zheng Junhua and Dr. Zhang Wenhong. So today I'm going to introduce the tool I use. It's a transition matrix model. I found it to be a very powerful forecast tool. So first, I've had some 20 plus years with financial modeling. My experience with COVID-19 is only 60 days. Well, it seems that there's some similarities, so I can utilize my skill set to forecast the COVID-19. So what is forecast? Forecast is basically to provide certainty in the world of uncertainty. So with good quality forecast, we can do better planning. We can do better planning with medical personnel. We need to know how many doctors, nurses, clinic staff we need. We can do better planning with medical supply, how many ICU beds, ventilators, N95 masks. We can do better planning with biohazardous waste disposal capacity, and also with government and policy and business practice. And most importantly, in the darkest moment, people, they want to know where is the end of the tunnel. They want to see the light and the end of the tunnel. So how can a financial model be applied to COVID-19 forecast? So I'm not a medical expert, but I'm very lucky to have friends, very close doctor friends like Dr. Zhang Wenhong and Dr. Zheng Junhua. So after consulting with them, I designed this flowchart to describe how a patient goes through the firstly goes through the close contact with an infected person, and then he will be put under medical observation. In China, generally, it's in a quarantine hotel for at least 14 days. And if he's tested positive, he will be identified as a confirmed case. If negative and no symptoms within 14 days, he will be discharged. So once he's diagnosed with confirmed COVID infection, he will, if he has non-severe cases in Hubei province, they will be put under this Fangsang shelter hospital, which are large makeshift hospitals renovated from convention centers, stadiums, shopping centers. And if their symptoms are severe, they will be put into designated hospitals. And obviously, if their symptoms become critical, they will be put into ICUs. And if the treatment is not successful, they will die, and that is the worst case. And it is a final or end event for this transition matrix. But within this COVID-19 treatment, we can say a severe case can transition into a non-severe case, and severe case can transition into a critical case. And also the cases, the stages, there's certain level of dependency, so they can change between these cases. So if we look at this mortgage servicing flow chart, we can find a lot of similarities. So normal mortgage can move from a regular payment mortgage into early delinquency. And if it doesn't cure by itself, it can go into serious delinquency in the second stage. And that stage, they can go through a loan modification, which is very like the treatment. In the mortgage servicing industry, we actually call it treatment. So actually, a person can self-cure, or they can cure by loan modification. And if the serious delinquent loan, it doesn't get any treatment, and it becomes even worse, it can go through a default. The default itself is also a bad event. So the purpose of mortgage servicing is very similar to the treatment of the virus. We want to minimize the probability of the bad event. So we conducted this forecast at the very beginning of February. And the very first, we were basically trying to forecast what is the turning point of this province. It seems that our model is pretty accurate during the month of February, which is a peak season for this COVID-19 virus in Hubei. So if we look at the number of peak active cases during the month of February, the actual number is 50,633. And in our forecast, under the cautiously optimistic scenario, the number is between 44,000 and 55,000. So the final number is between these two forecasts, and it's very close to the middle point. Next, we enhanced our model to predict the critical cases. So the actual critical cases peaked at 2,492 cases. And during, in our forecast under S2 scenario, our forecast is 1,986 to 2,484. So actually the critical cases is also very close to this range, only about 8 more cases compared to the second number. And the cumulative total cases at the February end is 66,907. Under our forecast, it's between 60,000 to 71,000. So again, the prediction seems to be pretty accurate regarding Hubei model. So after February, we learned a lot about this virus and how it can be controlled, given certain level of preventive measures, both inside Hubei and outside Hubei. So we utilize this model and we put out forecast for other countries. This model is built for Italy. So from this model, we can see we built 3 different scenarios. S1 is our benchmark, which assumes very strict measures and very good compliance from the people. So the final number would be pretty low. And the second measure would be less restricted and there's more wide outbreak. So in the second scenario, it's only about 60% of efficiency of the first scenario. And in the last scenario, which is S3 scenario, it's another downgrade of the efficiency. It's only about 60% efficiency of the second scenario. So only 36% efficiency of the first scenario. We tested the model on March 9th. And at that time, we predicted that Italy's situation is very likely to be S3, which means that it's going to be relatively pessimistic. So today, about 1 month later, when we look back, we find that the model has performed very well. The peak time for Italy until now is March 22nd. And in our model, our forecast for S3 scenario is March 23rd. So it's only off by 1 day. And the total number of cases today, I think for Italy, actually the number was, I got from the website of WHO, is 110,000 cases. And our model forecast is about 127 cases, 127,000 cases. So it's also relatively close because the model was developed about 1 month ago. That level of model error is acceptable. We also forecast for Korea, and we did the forecast on the same day as the Italy model. We forecast on March the 9th. So we backtested for about 3 days, and we found that Korea's situation is very close to S1. So during the first half months of the epidemic, we found that the model performed very close to S1 scenario. After March 15th, we find that actually the number of new patients didn't decrease, which is a little bit puzzling to me. So I consulted Professor Kwang yesterday, and he confirmed that the new cases are mostly imported cases. So actually the model has performed very well in the first half of March and would perform very well for the second half of March, excluding those imported cases. So a lot of my friends have asked me to make predictions about the US case. For US, the forecast is relatively hard because there's 50 states and Washington, DC. And each state is at different stage and the curve. And each state have different testing policies. So on the right-hand side, we can say this is a test positive ratio for different states. The highest one is Hawaii, it's about 40:1. The lowest one is Michigan, which is about 2:1. And New York, I think the name is not shown here, but it's also very close to 2:1. And David just mentioned in his hospital, the ratio is more like 3:2. So that's very alarming ratio. It means that a lot of the potential infected people are not tested. Also on the left corner, we retrieved this chart from CNBC on March 26. It basically measures the restrictions for different states during the coronavirus outbreak. And yellow means that the highest or the most strict policy. And the light blue means that there's no policy at all. And the dark blue means that somewhere in the middle with no essential business closed, but there's no stay home directive. Obviously, this chart is outdated because there has been new development of the case, and I think there's more strict state governments are enforcing more draconian measures. So we tried our modeling forecast for New York, and we found that under this difference, very similar to the previous model, we have S1, S2, and S3, and it seems that the New York model is somewhere near S1. So on one side it's a good sign. However, if we look at the test ratio, it seems that the number of test cases on the right side, it seems that there's only around 20,000 tests performed every day, and the positive rate is about 50%. So again, it's a sign that there's not enough tests. And also on the left-hand side, I retrieved the data about hospital beds and ICU beds, which we do not have the exact number. So I kind of calculated the ICU beds based on the population and the US average level of 37 ICU beds per 100,000 population. It seems that even under S1 and S2, there's not enough ICU beds. And I didn't put the S3 scenario here because go way off the chart. Obviously, here we do not know exactly how many severe cases in New York, and I use about 10% ratio. The ratio is pretty wide. Even in China, in Hubei province, the ratio is about 20% severe and critical cases. Outside Hubei, it's about 10%. So it seems that New York definitely need to do more testing and prepare more ICU beds. Even the forecast for the whole US is hard. We still try to perform some preliminary forecasting. Although the stability of the model is to be tested. We did the test on March 28. So it seems that up till now, the increased number is still below S1, but the increasing rate hasn't slowed very much. So very likely it would go beyond S1 and reach S2. Under S1 scenario, the total infection number would be around 500,000. Under S2, it will be around 1 million. So based on the forecast right now, it looks like the final infection number would be around between 500,000 and 1 million. And also we did the same test, we did the same calculation for the test statistics. On the right-hand side, we find that all over US, the ratio is about 4-1. So it is higher than New York, but still it's much lower than some other countries. Like in Korea, the ratio is more like 25-1. And in China, the ratio is 8-1. But it's very different inside Hubei and outside Hubei. Inside Hubei, it's more closely to 4-5-1. Outside Hubei is like 30-1. So we believe to adequately test every potential close contacts, the ratio need to be around 25-30. We have read some news about there's new testing kits developed in US, and hopefully with the new testing kits, the testing, there could be more testing and more quick testing. So overall, I think we are looking at this situation, which is pretty dire. And I would like to share this poem from English poet John Donne to express my feeling. It's basically, it says, no man is an island entire of itself. Every man is a piece of the continent. Well, right now, every man is a piece of the world. So any man's death diminishes me because I'm involved in mankind. Therefore, never send to know for whom the bell tolls. It tolls for thee. Hopefully, we will work together and fight this coronavirus together. And I will try to do my best and share my models with other fellow researchers around the world. Thank you.
Yeah, thank you, Dr. Cheng. And I just wanted to, could someone turn off that? Yeah. Okay, great. Again, thanks for Dr. Chen Jian. And all the PowerPoints and the slides and also video will be available. Hopefully, we will either post at the Brookings website or through our social media platform. People can also, welcome to contact us. We will be happy to send these PowerPoints to you. Now, let me ask a couple of questions for each of the panelists. Now, the first of all, for Dr. David Ho, as we know that the SARS-CoV-2, which causes coronavirus, novel coronavirus, is an RNA virus. The SARS-CoV and also HIV are also RNA viruses. Now, RNA viruses tend to mutate more easily, potentially leading to the deadlier or milder versions. Now, did this occur with HIV? How much should we worry about an even more dangerous virus causing a pandemic in the future? And what can the world do to prepare for or even prevent that possibility? David.
Well, the viruses you mentioned are indeed all RNA viruses, HIV, SARS coronavirus, and COVID-19. We know from years of research, RNA viruses generally have a high mutation rate, much higher than when our cells try to copy our own DNA. So the fidelity is much lower by 100-fold or 1,000-fold. So mistakes are made. One would think mistakes are bad, but when viruses replicate, it replicates by large numbers, and then by producing lots and lots of progeny and letting evolution take place, letting the fittest one survive. It does it by sheer numbers. Now, the mutation rate is actually also a molecular clock that allows us to see the changes, and then we could actually infer by backdating based on the sequence analysis. For example, we now know that by looking at the sequences of COVID-19 and comparing it with SARS and comparing with the like viruses in other animal species, particularly in bats, we now know that this virus probably is a recombinant form of two different coronaviruses. Probably that form took place not recently, but probably a couple decades ago, and residing in bat population and then infected humans. So I think we could dispense with the idea that some mad scientists engineered this for malicious purposes. But it also teaches us the fact that we have to be aware that these pandemics are zoonoses. That is, they are transmitted from animal species to humans. HIV was chimpanzees to humans. Ebola was bats through an intermediary or not to humans. And for both SARS and COVID-19, it's quite likely from bats through intermediary or not to humans. So we need to be aware of how the viruses behave.
Well, as a leading scientist on HIV, I wanted to ask you a question about the vaccine. Now, 40 years have passed since the outbreak of HIV. What was the reason an HIV vaccine never materialized? Could you comment on that? Maybe this is, early on you talked about the vaccine for coronavirus, but certainly, make us to think about the HIV virus, the vaccines. Could you comment on that?
Yes, HIV vaccine, as you said, is still lacking. It's not because of lack of effort or lack of support. In fact, it's now the holy grail of HIV research. But the short answer is the lack of a successful vaccine is because of the obstacles posed by the virus. The virus has a way of shielding itself at the external protein with lots of sugar, and that precludes very tight binding by antibodies elicited by our immune system. In addition, the diversity among HIV strains is so large that it's really hard. If you make a vaccine for one strain, it's really hard to cross over and protect another strain. It's basically these scientific obstacles that preclude vaccine development. I think we are not likely to face the same with SARS or with COVID-19 because we know we know. Could you hear me?
Yes. Yes.
Okay. We know the structure and the similarities are not quite there. So we hope vaccine development for COVID-19 or SARS will be much easier. But we need to remember one thing, though. I think as scientists race to develop a COVID-19 vaccine, it's been reported in SARS that antibodies elicited by SARS vaccines in animals could be at times be harmful and cause more severe lung injury because of what we call antibody-mediated enhancement. It is an aspect that must be resolved before we could move in an accelerated form into vaccine development and vaccine testing in humans.
Thank you, Dr. Ho. That's wonderful. Thank you for the very comprehensive analysis on that front. Now, I want to turn to Dr. Zhang Wenhong. Now, as the head of the Shanghai's anti-coronavirus clinical experts team, you are on the frontier of research and the treatment for coronavirus patients. Could you share with us about the drugs that China is used, including the use of Chinese traditional herbal medicine? I heard some of the stories. Could you comment on the drugs and also herbal medicine, Chinese medicine? on that area?
Okay. Actually, China, we are the first Chinese team that using every kind of the antiviral treatment for this new virus, including lots of antivirals, the little Librevia and also the Abidol, and including recently hydroxy chloroquine. And we noticed that lots of evidence that published by the just like French colleagues, they published a paper. They announced that the hydroxychloroquine have very good antiviral efficacy in these patients. However, according to our experience, we compare every kind of antiviral treatment. Actually, we did not find very significant difference between the different drugs. So according to our experience in China, I think up to now, we do not have any very strong evidence that for us to recommend any kind of the antiviral to treat the disease. So actually, we are waiting for the more evidence to help us to find the better drugs. So meanwhile, which is very, you mentioned that about the Chinese traditional medicine. So actually in China, I myself, we also used a lot of Chinese traditional medicine together with Western medicine. You know that China has used the traditional medicine herbs practice for thousands of years, long before the Western medications entered our countries. So therefore, Chinese doctors therefore are very experienced in using it to treat the patients. However, in this pandemic in Shanghai, so not separately use Chinese traditional medicine or Western medicine. Usually, the doctors here would use the integrated strategy of combined Western and traditional Chinese herbs in treating the patients. So far, what I can tell you is that no strong side effects were observed in our patients in this during we treating the patients here. The efficacy of traditional Chinese medicine currently, I think, is very difficult for us to evaluate because we do not take the monotherapy of the drug to treat the patients. Therefore, I think in the future, we still need lots of some good clinical trial to evaluate the Chinese traditional medicines to evaluate the efficacy of the monotherapy or combined therapy compared with the monotherapy of the Western medicine. Therefore, we still need a lot of clinical trial to evaluate the efficacy of the Chinese traditional medicine and also the integrated treatment of Chinese medicine and Western medicine. Yeah.
Okay, great. I have another question for you, Dr. Zhang. Are you concerned about the spread of the coronavirus in low-income countries around the world, especially in sub-Saharan Africa? Is there anything that more developed countries and the international community can and should do at this point? I also welcome Dr. David Ho comment on that.
Okay, actually, during our meeting today, my colleagues in Africa, they gave me some message about there's now recently there's some outbreak in Africa. So our team from China, so actually recently we have some colleagues now, right now, they stay in the Africa to help them to control the disease there. So actually recently in Sierra Leone, there's almost 7,000 cases were confirmed positive for the PCR. So therefore, I think there's a lot of crisis of the outbreak of the disease in the some zone in the world with a poor medical resource. I think it's really very dangerous. I never concerned about the situation in Europe or United States. I think if we have enough time, both the United States and Europe will control the disease. However, if in Africa and the South Asia, I think maybe in the zone with limited medical resource, it will be a problem. The fundamental and the most crucial impact on the epidemics would be that country, I think with sufficient medical resources, just like the United States or China, we should cooperate together in the invention for the vaccine and the antivirals. I think the effective antivirals and the vaccine in the finally, I think will help the South Africa or the Africa and also the South Asia to fight the battle against the disease. So recently, actually, we noticed that the crisis is there already. So in the future, I think we still need the cooperation between the China, United States, and some other country with sufficient medical resources. We should help other countries to together. If the crisis in the Africa or just like India and some other countries with limited medical resource, if we cannot control the plague there, I think the world cannot be good. So in the future, I think it's very important for us to work together. Yeah.
Thank you, Dr. Zhang. Dr. Ho, do you have any comment about the less developed countries?
Yes, I am actually quite concerned about waves of the epidemic hitting some of those countries that you just mentioned. In India, in sub-Saharan Africa, in some of the South American countries, wave after wave, and given the resource poor setting, the surge in patients would undoubtedly be overwhelming for the healthcare system there. The other thing is some of those countries are in the Southern Hemisphere. And as the weather warms and become more favorable for us in the north to deal with, it will become worse for them to deal with as the weather cools in the Southern Hemisphere. And so we must bear that in mind. And I concur with what Dr. Zhang has just said. I think the world better be prepared to help out in those resource settings, even though we are struggling with our own situation. And that's why earlier in my prepared remarks, I said we need to endure this together now and not wait. And some of those countries are not severely hit yet, and yet they need to endure with us and not allow the epidemic to take off. And they cannot relax just because the virus has not arrived at their front door yet.
Thank you. Thank you both. Now I turn to Dr. Cheng. According to the experts on the White House Coronavirus Task Force, the best case scenario, let me repeat, the best case scenario in the United States is that 100,000 to 240,000 Americans will die. You have applied your matrix modeling in forecasting both the infection rate and mortality rate in China. Now, could you comment on the forecast by your American colleagues working in the same area, including the very dire forecast just mentioned?
Okay, thank you for the question. That's a very important question. Let me step back. So let's take a look at the death rate. The final death rate in China is about 4%. But actually, inside Hubei and outside Hubei, the death rate is very different. Outside Hubei, the death rate is 1%. Inside Hubei, it's 4.7%. So why is so different? Because outside Hubei, we have a lot of medical resources and the health system is not overwhelmed. Inside Hubei, in the very beginning stage, it is overwhelmed. So the death rate is very high. And according to my numbers, in the very earlier stage, the death rate inside Hubei, the daily death rate from severe cases is 4% per day. But with a lot of medical resources, like Dr. Zheng Junhua's team, there's like 40,000 medical professionals. They went to Hubei and assisted, and there's new hospitals built like within 10 days, which can increase the ICU beds. The death rate eventually dropped very soon. And the final death rate of the severe cases on a daily basis is only about 0.2%. So that's like 20 to 1 drop. So I do not want to forecast the death numbers because that is not decided by the model. That is decided by how many medical resources are put into saving lives. But here, right now, in US, the current death rate is about 2.4%. Based on the number you just mentioned, that implies there's about 4 million to 10 million infected cases. Based on our forecast, we think it's not likely to happen. There's certain probability, but very small probability to hit that number. So I think right now, we don't need to concentrate on the number of death estimates. Eventually, it wouldn't be very accurate. What we need to know is how we can reduce this death rate. Thank you.
Thank you. Now, let me share with you some questions from our side, from people just sent in. Now, one question is for Dr. Zhang. Now, what is the estimated error rate in the test used in China to determine whether the person being tested is a confirmed coronavirus case? So in terms of, again, the question about the estimated error rate in China.
Okay. Actually, we in the first stage, in the first wave in Shanghai, we noticed that in some doctors in Wuhan, they mentioned that the false negative rate is very high for the PCR to detect the patient. I think it's very dangerous for us to to miss the positive patients, and it will cause a spread in the community. Therefore, in Shanghai, we just tested every kind of the kit, and we choose the best one to give the detecting for the patients. And every case, suspected case, we just do twice for the patient. According to our test, we found that if we will do twice for every patient, we will increase the sensitivity to almost 80%. So if the patient was highly suspected, just if the patient have the clue from the epidemiological area, and also have a very suspected phenomenon, the symptoms, just like a CT scan, the phenomenon, sometimes we will do the third time for the PCR. So therefore, for more times of the PCR, we will decrease the false negative rate. And furthermore, sometimes in my lab, I will do the next generation sequencing for the patient. If we do more for the patient, the false negative rate will decrease to almost near the zero. So according to our experience in Shanghai, recently, we just find almost every patient we can find. Even sometimes we cannot find the positive of the PCR, we still quarantine the patient for 2 weeks. So therefore, even though sometimes the false negative PCR, we still have the experience for the quarantine for the patient, we still can avoid the risk of the patients stay in the community and stop the spread of the disease. So therefore, the false negative detection, it will not be a problem in Shanghai. Yeah.
David, do you have a comment? David, thank you, Dr. Zhang. Oh, we cannot hear you. Yeah.
of course, I'd like to concur with, could you hear me now?
Yes, yes.
I concur with what Dr. Zhang just said. I think now we are gaining that testing experience a bit too late. Our current state of testing in America is sad and inexcusable. Our government sat on the sideline and dithered while watching China struggle in January and early February. But now, of course, PCR testing is increasing rapidly in the US. And as Dr. Zhang mentioned, the test is actually pretty accurate in general. But of course, collecting the sample is less precise. And if you don't collect from a good specimen, no matter how good the test is, it's not going to turn it up. In general, PCR is very, very sensitive. The other sad state of affair is that in the US, we are only just getting going with antibody testing. Those of us who are working in the field just assume US CDC had taken care of that, but no. And now we're doing antibody testing to supplement. And that's important because they measure different things. One looks for viral RNA and the other looks for body's reaction to the infection, and they should be used in complementary form.
Great. We only have a few minutes left. This is another question from a medical professional in Bethesda, Maryland. The question is, in the worst case scenario, if we have neither an effective treatment nor a vaccine, we have to accept that eventually most people will be infected. What would be the best strategy to handle this situation to minimize the loss of life? Very quickly, maybe start from Dr. David Ho.
Well, I think that's the question we all are asking ourselves. I think we could flatten the curve, but as I said earlier, if we flatten the curve and don't have a permanent solution, the cases will continue to percolate through the community.
Okay, great.
Albeit at a much lower level. And that means we would have to change our way of life for a long period of time. We certainly need to, I'm pretty confident that science will deliver, given the level of commitment that we're now seeing. So hopefully we won't be in that situation.
Thank you. Dr. Cheng Jian or Dr. Zhang, do you have anything to comment?
Well,
we only have 1 minute left.
Very quickly, and different stage, we have to concentrate on different things. And this stage, we don't know how long it will take to develop the vaccine or antiviral. But things we can do now is massive testing, social distancing, minimize the probability of getting infected, and minimize the death rate. So that I think we can do. And I think Dr. Zhang have much more experience.
Okay, good.
Let him elaborate on that.
Okay.
Thank you.
Okay, Dr. Zhang, do you have?
Yes, I think so. This year, I think it's highly probable that we cannot get any effective vaccine or effective drugs to fight the disease. So therefore, our only hope that after this summer, we wish that the plague can be decreased to nearly zero. So, however, I think still, because there are now some vaccine currently in the phase 1 clinical trial. So under current situations, I think the optimistic guessing that the vaccine could be out maybe next year. So in my opinion, I believe that is also shared by many of my fellows that vaccine development should be definitely needed in the end. The reason lies that the current global pandemic still see no ends, and the assumption of the persistent transmission COVID may not too wild a guess. Okay. For countries that less prepared or with less healthcare resources, the vaccine might be, I wait for that. So even though you think maybe we will not have vaccine, but actually we still need the vaccine to end the battle. Okay.
Okay, great. Now, as we near the end of this almost 3-hour-long webinar, I would like to take a moment to thank everyone who helped bring together today's event, including first and foremost, you, our audience, without whom these urgent lessons could not be shared and implemented in communities around the world. Many of my Brookings colleagues, especially Ryan Haas and Ryan McConvey, who planned and executed this logistically complicated event. Media platforms across North America, Europe, and Asia that have live broadcasts and amplify this discussion to a much wider audience. And last but not least, our speakers, and whose experiences and advice are invaluable to so many who are on the front lines combating this formidable virus as we speak. Now, the fact that most of our speakers are based overseas, mainly on the other side of the Pacific, reflects the imperative for international cooperation. In confronting global challenges like this, we all benefit from pooling our resources and sharing our wisdom and ideas. We are inspired by your participation, which symbolizes the conviction in and the commitment to our common humanity. With that, we conclude today's program. Stay safe and well. Bye.
Thank you.
Thank you.